Now the next is a shared research fellowship between Daulton Sauce and Kyle Rankin. They looked at the forgotten corner of the knee using digital segmentation to reconstruct the conventional anatomy, anatomical variations, and clinical implications of the posteromedial corner of the knee. And Dr. Withnell was their mentor.
All right. Hello, I am student Dr. Kyle Rankin. This is my colleague Daulton Sauce.
Howdy.
This summer, we shared a fellowship working on the study called The Forgotten Corner of the Knee, Effects of Joint Width on Bone Morphology. So there's not a whole lot of information out there on the posterior medial corner of the knee. This is due to a few reasons, including difficulty dissecting this region and imaging it. But what we did want to do was investigate how changes in width in this portion of the knee capsule can potentially implement bony morphology changes. So the goal of this was to develop a threshold width in this corner of the knee that clinicians can use as a red flag to alert them that potential workup could be needed for assessing for osteoarthritis. So the way that we did this is we used this program called 3D Slicer to examine MRI images that we gained from a database hosted by NYU. The 3D Slicer software allowed for accurate measurement from image to image by normalizing the distance, or excuse me, the scale for each image. So when we took our measurements, we knew we were getting accurate comparisons for each one. The way we did this is we measured from the adductor tubercle to the medial femoral condyle, then adductor tubercle to the tibial plateau in the coronal plane, and then took the difference from those measurements to give us our width in that portion of the joint capsule. The reason why we use the adductor tubercle, and we'll show you here in a minute, is because it's an easy to identify bony landmark.
So most OA patients don't present until they are, I guess, too far gone in the symptomatology. There's years of asymptomatic degeneration of that of the knee joint, and so hopefully by us elucidating a threshold, some measures can be implemented prior to becoming symptomatic. And also the typical endpoint for osteoarthritis is a total knee, and those devices really only last about 15 to 20 years. So there are patients who have OA that have to wait a decade before they can actually get a total knee. So by implementing measures now, would hopefully prolong that asymptomatic period.
So here you can see an example of the MRIs that we used. Behind this little laser pointer out. Let's see.
Oh, yeah, down.
There we go. You can see this little bump right here, which is our adductor tubercle. And then we would take our measurement from here down to the bottom of the femur. Let's see, there we go. And then we would measure down here to the top of the tibia, and then take the difference between these two measurements right here to get our data point.
So here's our data. We examined 1,002 knee MRIs. We found that an average joint width at that area of the knee was 5.44 millimeters, and the standard deviation of 1.39 millimeters. So corresponding to our histogram, you can see we do have some outliers. So we took all of that data and set it up into percentiles from 0 to 100, taking it at each 20th, and then took scans that had those exact measurements to serve as our models using 3D Slicer to hopefully elucidate some structure changes. And so here are the joint widths and their corresponding percentiles. And as you can see, we started, or the smallest was 1.78 millimeters, and the greatest was 9.71 millimeters. So there's a pretty drastic difference in the joint width amongst our population. And so we would hopefully be able to see some corresponding changes in the knee joint. Here are our preliminary models. Clearly you can see that there are some changes in the joint width based on each percentile, but the software that we use did not render clear images also can be seen on these models. So we really couldn't draw any conclusions about the change in morphology of the surrounding skeleton or skeleture. Is that a word? We're gonna go with it. Here's just some more models for us.
So we were not able to draw any accurate results on our study in this phase, but with more advanced software to make these models, we should be able to produce models that have high enough resolution for us to appreciate structural differences as they may arise. So we're going to use the software called Dragonfly, a really powerful program where we will be able to take the data set that we already compiled in 3D Slicer and take our representative scans, put them into Dragonfly, make our 3D models, and put together some 3D printed models where we can actually analyze them and see what we find. And with this in mind, better technology, hopefully we'll be able to find our threshold in the data that corresponds to our notable bony abnormalities and potentially improve patient outcomes in osteoarthritis patients. We would like to thank Dr. Withnell and Kansas City University for this opportunity to conduct research and providing all of your mentorship. Do you have any questions?
Any hands up? Okay, thank you very much, both of you. That was very clear and simple.
Nice.
That is nice. No, it's a very important way to teach your science, really. You did a good job. That's not an insult. Okay.